Assalamu alaikum, everyone.
वालेकुम
वालेकुम
सलाम।
सलाम।
So, the first thing that I have done today is to turn on the recording because somehow I forgot to do it yesterday and the entire session didn't get recorded. So, next time, somebody can just turn on their mics and let me know if I have forgotten to turn on the button. So, moving on, this is going to be a very brief review of yesterday's session. I'm going to go through it quicker. Do we have any new people with us today who didn't attend it yesterday, or all of you are repeating? Do we have any new people? You can just write in chat box if you don't want to talk. Okay, I think it's all of you have attended yesterday's session as well. So this is going to be a very quick review. You are all very familiar with the classification. We have four main groups. In fact, three main groups. The fourth one is just an add-on. The supratentorial ependymomas, posterior fossa ependymomas, you have spinal ependymomas, and in the end, we keep subependymoma as a leftover. All of the other lesions can be both grade 2 or grade 3, except myxopapillary ependymoma, which is only grade 2, and subependymoma, which is only grade 1. We have discussed radiology in really detailed way yesterday, so I would just go over it very briefly. This is a sagittal section, mid-sagittal section, T2 weighted image showing an intrathecal lesion which is completely occupying the thecal sac and obstructing the CSF canal. Here we can see that CSF column. It is completely obstructing the CSF column. We can see that this is a very well circumscribed lesion, slightly hyperintense on T2 weighted images. This is a rarer presentation. This is an intramedullary myxopapillary ependymoma, which you can see is taking up contrast here. It's intramedullary, and that is a rare presentation. Usually, myxopapillary ependymomas are extramedullary. Dr. Mustafa, please mute yourself. Okay, so this is another section, and we see that it's mid-sagittal section again, T1 with contrast. Post-contrast imaging, we can see that the lesion is very well circumscribed, avidly enhancing on the post-contrast images, and it is extending across three vertebral levels. It is most likely obstructing the CSF column as well, and we can see some heterogeneous enhancement pattern in the lower pole of the tumor, most likely representing necrosis or hemorrhage here. So this is another radiology following a very similar pattern, but the pattern of enhancement is slightly more heterogeneous here. It's not the homogeneously enhancing. And these are the axial sections. The first one is an axial T2. The second one is T1 plus contrast. And if you see, this is occupying the thecal sac completely and pushing the theca over here where my cursor is. And the same is happening here. But they appear better on T2 than axial T1 post contrast, at least in this case. Moving on, a very brief review. Myxopapillary ependymomas are WHO grade 2 tumors, essentially occurring in phylum terminal or conus medullaris, but there are a few case reports where they were intramedullary, but it's not something to be quoted on. If somebody asks you that where do they occur, you're just going to quote that they are in phylum terminal or conus medullaris. They are glial tumors that also stain positive for GFAP. Why is that important? It is important because conus medullaris and phylum terminal are also a very common site for chordoma. It's the second most common site for chordomas as well. So how do you differentiate them? You differentiate them with the help of the staining of GFAP. So, are you all with me so far? or gone back to sleep?
Yes, yes.
Okay. Okay, I was just checking because it's not as interactive since it's a review session. Okay, so they are most common in adults. Median age is 30 to 50, though it can occur in children where it is often more aggressive. And they typically present with chronic lower back pain, radicular pain, bowel bladder dysfunction due to nerve compression. Why is that important? We discussed that in very thorough manner yesterday. I'll just briefly repeat it. If a patient who is 30, late 30s, early 40s presents to you in your clinic and tells you that he has a new onset lower back pain, which is radiating down the leg, and you might assume that this is most likely a degenerative disc disease. But sometimes the spinal tumors can also present with a very similar presentation. And in such tumors, you have to ask about the red flags. The red flags here are going to be nocturnal pain and pain that worsens while the patient lies down. So you have to ask for the red flags. They are the only clues which can be present in the history. Otherwise, 40s is also a very typical age for degenerative disc disease. So, histopathologically, they are characterized by myxoid backgrounds and papillary arrangements. Grade elevation. We discussed it very thoroughly yesterday. Why it is elevated to grade 2 from grade 1, because if you read the older text, the Schmidt or any other older text, and there are some texts on pediatric neurosurgery, if you read Myxopapillary Ependymoma, they would mention that it is grade 1. Why was it elevated? It was elevated due to its extremely common occurrence of recurrence. What ends up happening is, if you breach the capsule during surgery and do a subtotal resection, the myxoid fluid leaks out into the entire craniospinal axis and ends up with leptomeningeal seedling. That is the reason it is no longer considered benign, because the rate of local recurrence is very, very high. So, we have NCCN guidelines and EANO guidelines. Why are they important? They are important because we know what to do next. If you are appearing in any exam, always mention the guidelines you're talking about. Best is do not mention, only mention the textbook. If they ask you about the recent advances or the recent guidelines, then you can mention. And the best policy is to always mention the name of the guideline, because sometimes there might be a difference in how some regional guidelines treat different pathologies. Not talking about myxopapillary ependymoma, just a general disclaimer. So, surgical management is the primary treatment. Gross total resection is the gold standard. Our aim is to go for en bloc resection. How do we do that? We do that with the help of intraoperative neuromonitoring. We use MEPs, we use SEPs, we use EMGs, and with their help, we try and confirm every single nerve root that is arranged around the tumor. And once we identify the nerve roots, we separate them very gently and we try to get the entire tumor out. Sometimes, if complete resection is not possible because of how entangled it is with the nerve roots, then we can leave a small rim of the lesion as well. And that's also a very likely possibility. So, radiotherapy guidelines. As I mentioned, if you have done gross total resection, if you are 100% sure that you have taken out the entire tumor and there is no residual which is left behind, then observation only is acceptable. If you have even a small doubt that you have done subtotal resection and some tumor might be residual on the nerve roots or on the phylum terminal, then the best option is to go for adjuvant radiotherapy. It is strongly, strongly recommended by both NCCN and EANO. Typical dose is 50.4 to 54 grays, which is delivered in focal fractions. The entire excess radiation is only recommended if there is evidence of drop metastasis. If you find sugar coating or leptomeningeal dissemination on MRI, whole spine and brain with a post contrast, only then you are going to go for the entire axis radiation. Otherwise, no. This is the staging and surveillance updates. It's very difficult to remember the entire thing, but you can always go back and take a look at the PPT. CSF, CSF cytology is recommended 2 weeks post-op. The initial staging is just the MRI of the entire neuraxis. CSF cytology is not a part of the initial staging. Somebody did ask me that yesterday. I think it was Dr. Hussain. We discussed that in the open house, which is the second presentation. NCCN follow-up is for the first 3 years, MRI every 3 to 4 months. For years 4 and 5, every 6 months, and onwards, you can do it annually. So, subependymoma, are you all with me?
Yes, ma'am.
Okay, so moving on, we have subependymoma. We did discuss the vascular anatomy in detail yesterday. So I'm only going to describe the radiology. This is a mid-sagittal section. You can see an iso to hyperintense lesion in the posterior fossa, ideally in the fourth ventricle, which is causing some amount of compression on the brain stem. It's also causing some compression on the cerebellum. There is obstruction here in the CSF pathway as well, and the lesion appears to be well circumscribed. So, somebody asked me about these vessels yesterday, and they are most likely the lateral posterior choroidal arteries, but I can't be 100% sure, obviously. But they are most likely either lateral or medial. Medial usually loop slightly inferiorly, lateral loop slightly above, so they can be lateral posterior choroidal, according to the best of my knowledge. Is my voice clear? Is my voice clear?
No,
Is it breaking?
no, Dr. Kam. Yes, it's breaking.
Okay, is it better now?
Yes.
Um, just give me a minute. I received a message that my internet connection was unstable. I have no idea why that has happened. Is it better? Is it better now?
Yes, it's better now.
Okay, so proceeding. So these are axial sections. The first one is flare, the second one is T1 post contrast, and you can see an intraventricular lesion which is well circumscribed, hyperintense, and it's attached with the lateral wall of the lateral ventricle, causing some compression over the septum pellucidum, but not much. And on post contrast images, you cannot even see the lesion because it is iso-intense, completely similar in intensity with the brain matter. This is another image of a subependymoma. You can see that it is intraventricular and hyperintense, well circumscribed, appears to be lobulated. There are multiple lobules here. It is causing a lot of compression over the septum pellucidum. There is a beginning of hydrocephalus in the ipsilateral lateral ventricle, but CSF seepage is not seen, so it's not full-fledged hydro yet. This is a fourth ventricular lesion, and you can see how beautifully it is going between the two cerebellar hemispheres. The lesion is iso to hyperintense, well circumscribed, causing completely occupying fourth ventricle and causing some compression over the brainstem as well. So, these are WHO grade 1 tumors, arise from ependymal lining of ventricles. 50 to 60% occur in fourth ventricle, 30 to 40% in the lateral ventricles. Usually, they are not detected. They are only found as incidentalomas. Patient had some other pathology. They had a trauma, a minor, anything else that led them to have a scan, and that scan ended up picking up a subependymoma. Usually, they do not cause any problems. They are non-invasive. They are completely inactive mitotically. So, when they are symptomatic, they cause signs of hydrocephalus, headache, nausea, vision changes, vomiting. We know how the hydrocephalus presents and raised ICP presents. That is their presentation if they end up blocking the CSF pathways. Typically, they are well demarcated and non-enhancing. This is really, really important because as Dr. Hussain made this comment yesterday, that when you find an intraventricular lesion, you have to keep the possibility of SEGA, and SEGA enhances usually. Subependymomas do not enhance at all. It's a very important radiological feature. Yes, there are a few case reports. Sometimes they do end up enhancing, but their general behavior is that they do not take up any contrast. Gross total resection stays the gold standard. If treatment is ever needed, and when would they need treatment? Obviously, when the patient develops some obstruction of the CSF pathways and patient develops hydrocephalus, that is when GTR comes up in the discussion. Otherwise, usually they don't need any treatment. If for some reason gross total resection is not possible, for example, the tumor is in fourth ventricle, it is compressing the brainstem, or it is attached densely to the brainstem or the floor of the fourth ventricle, then you don't do anything. You leave a residual. Why? Because they are extremely indolent. They don't do much. And that's a wrap for yesterday's review. Um, Moving on to the other presentation.